My pleasure to welcome Dr. Lori Brotto as our speaker today. Lori is a professor. I got to put my glasses on. I probably know this all off by heart, but I better put my glasses on so I don't miss anything. A professor at the UBC Department of Obstetrics and Gynecology, and she's a registered psychologist. She is currently the executive director at the Women's Health Research Institute at BC Women's Hospital, and she took over this role about 3 years ago.
3 years and 2 months.
Not that she's counting. She's not counting. And I would say completely revamped WHRI. So it is really, I would say, the go-to source in Canada for women's health research. So I really applaud her for that. She holds a Canada Research Chair in Women's Sexual Health. She's a director of UBC Sexual Health Laboratory, where her research, which we'll hear about today, primarily focuses on understanding and managing sexual concerns and genital pain in women. She's also the associate editor for Archives of Sexual Behavior and has over 150 peer-reviewed articles. She's passionate about knowledge translation, boy is she ever, and as such she's frequently featured on the media on sexual health topics. And if you haven't seen her yet on Jen Gunther's new show called Jensplaining. I knew it was something splaining. Couldn't remember. Jensplaining. I urge you to watch the whole program. It's all really great. And you're on episode 8 or something. Do you remember?
The last one.
The last one, maybe 10. Anyway, they're very good. They're on CBC Gems. So if you have a streaming service, it's free. You can look that up. She has a book. It's called Better Sex Through Mindfulness, How Women Can Cultivate Desire, from Greystone Publishing. And it's a book that refers to her research over the last 15 years, demonstrating the benefits of mindfulness on women's sexual concerns and genital pain. So, without further ado, I welcome Lori Brotto.
Thanks, Lisa. Can everyone hear me okay? I'm going to use this mic, and I'm just going to mute the lectern mic. Thank you. You read my mind. Can people still hear me? And how do I know if folks in the ether can hear me? Assuming they can? Okay. All right. Great. So great to be here, and great to have the opportunity to do a bit of a bird's eye view reflection on some of the work that my lab has been doing the last 15 or so years on women's sexual health. And just fabulous that we have this Women's Health Lecture Series that Dr. Galea and Emma have put together. I'm actually looking forward to all of the talks. I hope to save room for questions at the end, but do feel free to interrupt me throughout if you want me to go down any rabbit hole related to women's sexual health. I'm more than happy to. And so really my remarks today are going to focus within the broad domain of women's sexual health, more specifically on our work in adapting and testing and then applying mindfulness-based interventions for various populations of women with sexual health concerns. I'll share with you some of sort of our high-level findings, some of the things that have been getting me really excited over the last few years, and then, of course, some of the controversy, which I think is really important for each of us as researchers and consumers of the science to keep in mind is what are the alternative explanations or the other views of our own research. So just a little bit of background, and I often get asked this question, which is how on earth did I come to devote most of my life to researching women's sexual concerns? And one of the things Lisa didn't mention is that as a graduate student, I was mentored by folks in behavioral neuroscience, including Lisa, where I primarily studied animal models of sexual dysfunction and did that for about 6 years. And then in 1999, which was the year that I started my PhD, there were a couple of really notable things that happened that year that led me to switch tracks and move on to clinical research, and specifically with women. The first was the approval of Viagra. Viagra was approved the year before in the US, but in 1999 it was approved in Canada. And it truly was a blockbuster moment in the field of treatment of sexual concerns. Suddenly, men who experienced erectile dysfunction, or ED, had something that was effective, safe, easy to use, very discreet, effective on demand, and was prescribed and endorsed by the masses, including the big billboard ads that you saw of former Bob Dole, who wasn't shy to speak about his own ED, and that after those ads were available, we saw the sales of Viagra just skyrocket. And so we had this medication that was available for men's sexual concerns, and that same year, this very, very large study was published in the Journal of the American Medical Association looking at how common are sexual concerns and sexual difficulties in men and women, and this striking statistic of 43% of women, in fact, it's even in the abstract, 43% of women have sexual dysfunction. Stark. Half of women essentially have a sexual dysfunction. I can't think of any other medical or mental health condition where we would say that half the population are afflicted by it. I'll get into some of the weeds of unpacking that number in just a bit, but really this combination of having something quick, easy, effective, cheap for men, and yet having double the rates of sexual difficulties in women than in men, and yet no available, approved, safe, effective medication for women. And even in looking at the psychological literature, very, very little was published on effective psychosocial approaches and skills. Really, the bulk of the work had been done by Masters and Johnson back in the 50s and 60s, and for those of you who watched the series, Masters of Sex, fairly accurate portrayal of the research that they did and how it then led to the most commonly used therapies that we still use today for sexual dysfunction, essentially structured touching exercises, which we call sensate focus. So what's happened since then, since the era of Masters and Johnson until the late 1990s in the domain of treatment for women's sexual concerns? Surely there's been more that's been done. And so that really, again, led me to pivot on my research track and then began doing research focused on women's sexual function and difficulties. So unpacking that 43% figure just a little bit, and the devil really is in the details, because when you ask someone over the last year, have they had any sexual concerns, chances are that if someone is sexually active, they've had a difficulty of some sort over the last year, right? A period of stress that's interfered with their desire, a medical issue or use of a medication, or a physical issue that's interfered with performance or arousal or ability, some other relationship conflict or issue that interferes with one's ability to be present during sex. So we need to be much more specific in how we ask about sexual concerns, because not every sexual concern is a dysfunction, and not every sexual difficulty needs to be treated. So when we look at the more methodologically rigorous data, a lot of this has come out of the UK, the big NatSol studies, which recently published its third wave. So the first wave was done in the mid-90s, and then 10 years later, and then 10 years later. Very large population-based prevalence data that involved interviewers literally going door to door and asking people over the age of 16, if they have time to answer a few confidential questions about their sexuality. Very interestingly, and I won't be sharing any of the findings, but what they found was among 80% of the women who agreed to answer the questions, 80% of them also provided a vaginal swab. So they left the interviewer downstairs, went off to their bathroom, collected a sample, and provided it. And so there's a massive repository of information looking at vaginal and vulvar health, et cetera. They also provided a salivary sample, too. So what do we know based on the NatSol questions? So the main question that was asked was, over the last year, have you had a period of 3 months or more where you had a significant sexual concern? And then it was broken down into the major categories of sexual functioning: loss of interest in sex, difficulties getting aroused, anorgasmia or difficulty reaching orgasm, pain with sexual activity, lack of satisfaction, and discrepancy in your level of interest in sex and a partner's level of interest in sex. And what the study found, lo and behold, there's that about 50% figure again. 50% of them said over the last year that they have had at least one of those difficulties for 3 months or more. You can see a quarter of the women said they had 2 or more of these difficulties. On the right are the comparable figures for men. So you can see the numbers are a little bit lower, but still pretty high, 40% of men saying that they have a sexual difficulty over the last year. Now, where it becomes really important when we think about a sexual dysfunction, which there's various ways of classifying sexual dysfunction. We commonly use the Diagnostic and Statistical Manual of Mental Disorders, or DSM-5. And the DSM-5 requires the presence of a symptom plus clinically significant personal distress. So these figures don't capture that, right? So about half of these individuals captured in that 50% figure are not bothered by it. They can explain their sexual difficulty by a current life circumstance or a current illness or a period of stress, and so they're not distressed by it. So that factors in when we think about treatments, because we really want to be offering treatments to those individuals who have the concern and are distressed by it. All right, what about some Canadian data? Relatively less, really no population-based study looking at sexual concerns in women and men across Canada, but we do have a bit on desire. So this was a study that's, a large study that has been published over the last couple of years. And really the comparison here was to the women who had clinically significant low desire, which is the most common sexual concern in women, and by the way, in men too. Low desire is more common than erectile difficulties. And so this study compared the two groups, those with clinically significant low desire and those with quite happy levels of desire. And it was focused mostly on, it was focused entirely on midlife women. So the additional question of what role does midlife and the perimenopause have? Okay, so one of the things to take away from this slide is when the data were separated by age cohorts is now, albeit this was only from age 40 to age 59, but not a huge difference in the prevalence of low desire across the ages within that. And there's often a myth or belief in the popular media, which is menopause is the end of women's sexual desire. And there have now been countless different studies, longitudinal, cross-sectional, using a variety of different methodological approaches that have largely debunked that menopause is not the end of sexual desire for women. However, there are some other factors that consistently come up as being associated with low desire for women. So, for example, overall health status. So just to quickly orient you to the next several graphs, the red bars reflect the women with clinically low sexual desire, and the blue bars are women who are quite happy with their level of desire. And so when you look at the association of low desire with overall health status, what you can see on the far right-hand side is women with low desire are more likely to report poor health, and women with happy levels of desire, satisfying levels of desire, are more likely to report excellent health. And that finding has been borne out over and over again. What about the association with sexual satisfaction in the relationship? Again, looking at the far left, the women with satisfying desire were more likely to also say they were sexually satisfied overall in their relationship. And on the far right, the opposite of that, the low desire women saying that their level of sexual satisfaction in their relationship was lower. Pleasure at last sexual intercourse, and I should make a point of saying that in this study this included women who have sex with men and women who have sex with women. So intercourse in this sense is defined as any vaginal penetration, whether it was penile vaginal penetration or penetration with a dildo with whatever gendered partner. And again, you see this association. The women with satisfying desire were more likely to report their encounters as being pleasurable than the women with low desire. And of course, this begs the question, well, maybe their desire is low because their encounters are not satisfying, right? So maybe it's the loss of pleasure and the loss of arousal that's actually driving the low desire. And that hypothesis has been tested in a variety of different labs, different settings, and there's a lot of support for it. And so then when we flip over to think about treatment approaches, some women do respond quite well to improving the quality of the sexual encounters that they're having, and in particular a focus on pleasure, and then the desire rebounds after that. Sexual communication, this factor again has been studied over and over again. The women with low desire are more likely to say that they never communicate about sex with their partner or express their wishes and wants or how to touch differently. And on the other hand, the women with a satisfying level of desire on the far right, they very frequently communicate to their partners about sex. And then finally, from this study, looking at the women with low desire, the percentage of them who had talked to a primary care doctor about it. And you can see that a third of the women with low desire spoke with a family doctor, or in other words, about 2/3 of them did not speak to a family doctor about it. One of the conclusions that we can take from that is that a lot of women with low desire, or let's say sexual health concerns in general, don't talk to a healthcare provider about it. Instead, they go online. They often read magazines, and I'll go so far as to say a lot of the information that women are exposed to in magazines and popular websites is not evidence-based. And in fact, some of it can actually be dangerous information. And Lisa mentioned Dr. Jen Gunter and the hashtag Jensplaining series, which is a 10-part video episodes on the GEM CBC network. And really the intention of that series is to expose a lot of the misinformation that women receive about their health in general. There's an entire segment on sexuality. So taking a bit of a step back, another sort of interesting finding in the literature was this finding, which was that 21% of individuals who are in a relationship have not been sexually active in any way over the last year. So this is after you control for things like unavailability of a partner or other explanations of not engaging in sexual activity. So 1 in 5 people over the last year have not engaged in any kind of sexual contact with their partner. And there were some predictors of that. Women were more likely than men, older women more likely than younger women, married, more likely than married, and those individuals with more conservative attitudes. So those were the 4 main predictors of who was, quote, sexless in America, or sleepless in Seattle, if you will. There's been another study that's received a lot of media attention over the last few years, and there seems to be this societal preoccupation with what is that magic number? What is the frequency of sexual activity? That's probably one of the top 5 questions. Am I normal? I'm only having sex X times per week, month, year, decade, fill in the blank. And so this has been studied, and what we do know is that when you compare frequency of sexual activity rates today versus 20 years ago, and you can see the trend there, that on average people are having 7 times fewer sexual activity encounters than they were 20 years ago. Unfortunately, the study is not able to really answer the big burning question, which is why? What on earth is going on? What's happening in today's society, given the fact that we live in such a pro-sexual society where hookup culture has been normalized, where we can swipe right and find a sexual partner almost immediately, where consensual non-monogamy has been normalized, where divorce is common and accepted, where we have sort of embraced the idea that if we're not happy in a relationship, we can just leave. And so all of those factors really seem at odds with this figure, which is how on earth could we be having less sex today than we were 20 years ago? And I'm not going to answer that question for you. I've been interviewed on this question lots of times. I can speculate. I think one of the reasons is low desire, and we do see rates of low desire increasing. We also see increasing rates of solitude. and far less interaction, so just general social interaction among people. So are there actually fewer opportunities to engage in sexual activity despite the sort of image and impression, which is everyone's having sex all the time? Clearly the data suggests that we are not. Okay, let me just fast forward here a little bit. So this slide here sort of sets up the rest of my presentation because in the big NATSOL study that I presented earlier, the big British study, 15,000 individuals who were interviewed, they looked at what were the biggest predictors of low desire in women specifically. And again, this gets to some of the questions that are posed around, is this hormonal? Does this have to do with an imbalance of serotonin and dopamine and norepinephrine in my brain? And many of the very, I think, understandable and logical questions that people would ask, which essentially, what's the biological underpinning to this? And so as you read through the list and you look at the main predictors of low desire, physical and mental health variables, living with a partner, difficulty communicating, one's attitude, concurrent health conditions, relationship duration, not feeling emotionally close, lacking enjoyment in sex, again, that pleasure component, and limited arousal, we can see that a lot of those tap more so into psychological and social variables than they do necessarily hormonal or physiological variables per se. I don't want to set up a false dichotomy because, of course, all of these things have a physiological manifestation within our brain and within our body. However, on the other hand, when an individual presents for treatment about a sexual health concern, often if that person is seeing a family doctor, again, the logical first step would be, measure their hormones, do a physical exam. 99% of the time, all of those markers are totally normal. So again, the logical question would be, we've had Viagra since 1999. Surely there must be a pink Viagra. And guess what? It's here. It's finally here. Yay, we have a pink Viagra. Not so fast. So Phlebancerin is approved in Canada. It was approved last year. It was approved 4 years ago in the United States. It's a failed antidepressant that originally was tried in the mid to late 1990s for the treatment of depression. Wasn't effective at all for depression, but a side effect, I'd say maybe a positive side effect of this medication, was that a subset of the samples that were studied reported an increase in sexual desire. So, of course, the pharmaceutical company, being smart, they said, well, there's a much bigger market for sexual concerns than there is for depression. And that then launched a 20-year, very, very detailed, very expensive clinical trial looking at the efficacy of Phlebancerin for the treatment of low desire in women specifically. So Phlebancerin was approved on its third try at the FDA. The first two times it was not approved mostly due to marginal efficacy of Phlebancerin over and above placebo. And to give you an actual number to put around this, and there have been 3 meta-analyses now that have looked at its efficacy versus placebo. And placebo group in general in drug trials is essential. I would argue it is paramount in the study of sexuality, where expectancies, where the wish for things to be different, where the level of helplessness and hopelessness maybe is arguably higher. And so placebo rates within research tend to be higher than, say, in the comparable literatures of depression and anxiety and chronic pain medication. So what the 3 meta-analyses found was on the primary outcome variable, which is, or the outcome measure, which was sexually satisfying events per month. Interestingly, it wasn't low desire as the primary outcome, it was sexually satisfying events per month. That Phlebancerin, or ADDI, as it's commonly known, increases the number of sexually satisfying events over and above placebo by 1 in 2 months. 1 in 2 months. And these are among the 11,000 people who were already having sex at baseline. So if they were having sex 4 times over the last 2 months, they would have 1 more encounter that they deemed to be sexually satisfying compared to the placebo group. So some of the downsides of Phlebancerin: it does have to be used daily because of its mechanisms of action. In the United States, it's very expensive. We actually don't yet know the costs in Canada because it's not yet available in across the different provinces, even though it is approved. It is approved only for premenopausal women, again, so ignoring the other half of the population of women who have low desire concerns. Many of the women who were using medications for common yeast infections or bacterial vaginosis or other common vulvar and vaginal conditions and were using medications for them were excluded from the trial. And so any woman who's using any antifungals for yeast infection, it's contraindicated with this. Similarly, women in the trials were not using hormonal contraceptives. And as I mentioned, women in the trials were already sexually active at baseline. And I can tell you, based on my clinical work with women, that most of the people I see with low desire are not having sex, and that's why they're seeking treatment for it. So the question is really, for whom is this medication really approved? My own feeling is that there is a small market of women who would benefit, but the science has not yet identified who those women are. I think until it does, that this medication should not be prescribed on a widespread base for women with low desire. Oh, one more thing, totally contraindicated with alcohol. That's kind of a big deal. And in the qualitative, you almost don't even need to do qualitative focus groups to find out women's feelings about this contraindication with alcohol. So the mix between alcohol and Phlebancerin led to dangerous drops in blood pressure. Okay, so let's shift just a little bit. And I put this figure on the slide because, well, one, I think it's a figure that a lot of us can relate to, the sort of epitome of multitasking, handling everything at the same time, whether it's the multiple roles that you have or the multiple demands you have within one role. And also, I think what we hear a lot of in contemporary society was this almost prizing of our ability to multitask, right? I'm such a great multitasker. Isn't it fantastic that I can, bake a cake and eat dinner and help my child with homework and finish my grant off and do my online shopping all at the same time. And I think there's a lot of messages in society which suggest that we just need to be better multitaskers. And if we were better multitaskers, that would be the antidote to the increasing levels of stress that we see in society. And the Stress in America survey, which is published not every year, every couple of years, is finding rates of stress creeping up with every year. And yet the reality is, and social science and social psychological literature has really looked at this question of, is there such a thing as good multitasking? Is this a skill that we can hone and get very, very good at? And the literature there is completely unequivocal. It suggests that it's totally an illusion, that we can't truly multitask. Each time that we shift from task to task, there's a cognitive load that is associated with things like slowing, increased chances of error, less satisfaction in the tasks that we're doing, problems with memory and encoding, etc. And instead, what it suggests is that we're not actually multitasking, but rather we're serially tasking from one task to another. And each time we do that, that there is a cost. Those in the mindfulness literature would suggest an overhaul of this notion of multitasking, and rather than prizing multitasking, can we do one task and finish? And maybe it's not take it to the completion, but can we define a start and an end time to a certain task before we move on to another task? So mindfulness has a definition which is probably not new to anyone in this room, but is helpful still to just clarify the more contemporary definitions of mindfulness. There was a consensus panel in 2004 which defined mindfulness first and foremost as non-judgmental, and so that suggests that when we pay attention, we do so in a particular way, and it's non-judgmental and with compassion. That it's present-centered, so it's focused on the here and now as opposed to what just happened 10 seconds ago and what's about to happen. And it's mindfulness that treats all thoughts, all emotions, all body sensations, whatever arises, as something that we can pay attention to. So even thoughts we can pay attention to without getting wrapped up in the content of those thoughts. So we can say, oh, I just had a distracting thought from the door opening, right? So it was distracting, as opposed to who walked in, why did they walk in late? So it's our ability to kind of from a distance observe the fact that we are thinking. It's thinking about thinking, or metacognition, if you will. So really the two parts of mindfulness, one part of it is that attention training and focused concentration, and the other part is orienting to our current experience in an open, compassionate, non-judgmental way. So my own, oh yeah, I put actually, you're probably wondering why does she have puppies on her screen, besides the fact that I adore dogs. It's if we can have the same sort of approach with our mind as we would a curious puppy whose attention is drawn here and there, of course, because that's what puppies do, they're curious. And if we can have that same approach to ourselves when we get distracted, which is, this is a feature of the mind. The mind is like a curious puppy in that it's going to be drawn to different things, and that's natural and that's normal. And my role is to gently guide it back, rather than saying, oh my gosh, I'm so distractible, I can't focus, what's wrong with me? Everyone else can hold lotus pose for an hour and I can't, I hate yoga, all of which I hear when I teach mindfulness classes. So it really folds in and emphasizes the compassion piece as we practice. So I'm going to shift now and spend the remainder of my time sharing some of our findings on applying mindfulness to different populations of women. And my own introduction to this happened when I did a postdoctoral fellowship at University of Washington, Seattle, and was introduced to mindfulness through a very different route, and I won't get into the whole story, but at the same time I was doing sex research with cancer survivors, mostly women with gynecologic cancer, who reported first and foremost being cut off from their feelings of arousal after their radical hysterectomy. These were early stage cervical cancer, and given the types of treatment that they experienced, many of them said, you know, I don't feel anything anymore. I feel myself touching, I feel my partner touching, but the qualities of pleasure and connection and sensuality and tingling are simply gone. And so at the time I was learning mindfulness in a totally different population of individuals with borderline personality and doing research focusing on sexual concerns among cancer survivors, and thought, you know, there's some similarities here between the kinds of things that these different populations are saying, and could mindfulness maybe fill a small gap for them in helping them to feel again. So that then sent me down a track of fully immersing myself into reading about mindfulness, going to retreats. The first book I read was Thich Nhat Hanh's Miracle of Mindfulness, which is fantastic. You'll never wash the dishes in the same way after reading The Miracle of Mindfulness, because Thich Nhat Hanh talks about making washing dishes, which is something I think we all hate, but making it a mindful experience. And then read the incredible work of John Kabat-Zinn, molecular biologist who really introduced mindfulness into the Western healthcare setting and recontextualized it from something that Buddhists did in lotus pose in rows to something that we could incorporate into our contemporary settings. And his entry was through chronic pain, where he developed mindfulness-based stress reduction, a formal and structured 8 to 10 week group where he taught people with chronic and debilitating pains how to live with those pains. The intention wasn't to get rid of the pain, wasn't to make them feel less pain. It was, how do we keep living alongside your chronic pain? And since MBSR has been developed, there's been about 30,000 people around the world who have gone through a formal MBSR group. There's lots that are run in the greater Vancouver area, and lots of local people who are trained and certified in delivering MBSR. From there evolved mindfulness-based cognitive therapy, which has emerged as a very, very useful treatment for the prevention of depression relapse. And the idea with mindfulness-based cognitive therapy is, how do we treat depressive thoughts as mental events, something that the brain does, rather than something that's conveying a particular message to you of salience, right? And that was often seen as the real sticking point in preventing depression relapse, was we could only get so far with our evidence-based cognitive and behavioral approaches, but it was the contents of these recurring thoughts, right? I'm not good enough, others are doing better, what's wrong with me, that was mostly resistant to cognitive behavioral therapies. And so mindfulness-based cognitive therapy, which essentially taught people to just observe these as something the brain does in the same way that your gallbladder produces bile. And it worked, and it stuck, and it's become a really important tool in our tool belts of treating depression. Okay, so let me fast forward now. Here's just a few interesting slides that show the explosion of the empirical literature on mindfulness. There's an entire journal of mindfulness, and you can see since 1980, which was the first year that Jon Kabat-Zinn reported his outcomes from the pain clinic through to today, you can see that there's really been just this explosion of empirical papers. You read about mindfulness in the corporate sector. Google has a Find Yourself room where CEOs encourage employees and staff to take time in their day, not take time out, but put time in to meditate, because, again, the data are pretty compelling in terms of impact on job quality and performance measures. And there's been a number of magazines devoted to the topic of mindfulness in different populations, lots of books. Okay, so bringing this back to sexuality now, if you all in the viewing and listening audience were to think back to any sexual encounter you've had or may have had in your life, and if I were to go around and ask you the details of that encounter and what made it so optimal, what made it so fantastic, chances are we'd hear dozens and dozens of different stories. But I can almost guarantee that there would be a commonality across all of the stories, and that is when individuals will unanimously describe feeling present, feeling connected, feeling in the zone, feeling totally in sync, again, regardless of the details of what's actually happening. And so I would go so far as to say that mindfulness is not only a helpful tool for improving sexuality and sexual function, it's probably a critical ingredient for satisfying sexual encounters. We don't have time to do practice, unfortunately, so instead I will encourage you for the rest of the talk to just sort of tune in to any sensations in the body that arise and just take note of them as you continue to listen to some of the data. So I mentioned that my own research bridging mindfulness with sexual concerns started in Seattle, and this was really a very, very primitive pilot study that we had done. My supervisor and I at the time, and she had no background training in mindfulness at all, we pieced together the ingredients of a 3-session intervention that we could then use in partnership with the folks at the Seattle Cancer Care Alliance that I was working with. And it was a small sample of 22 survivors, all of whom reported feeling disconnected from their sexual response and low desire and mostly lack of sexual feelings. No control group. I was the only person doing the intervention and giving all the questionnaires, so tons of caveats to keep in mind when you look at the findings. But essentially what we did was look before treatment and after. Some of the main measures we have, so the upper left-hand corner, we have a sexual psychophysiology lab where women insert a vaginal probe, and it's one indirect measure of physiological sexual arousal. It doesn't tell you anything about what's happening in the woman's brain or mind, but it does indicate, does she have a physical response to erotic stimuli in a controlled lab environment? And decent effect size of about 0.39 increase from pre-mindfulness to post. The upper right was women's perceptions of their own physical arousal, again, not mental arousal, but perceptions of physical, effect size of 0.5. Their self-reported arousal, so the question here would be how much sexual arousal do you experience in your mind when you're shown erotic stimuli, went up. And also their perception of autonomic arousal, so their feelings of increased heart rate, skin sensitivity, other measures of ANS activity also went up. So there was enough of a promising story in this study that it led us to say, let's look in more detail at this. So we then did a follow-up study, and this time we had a delayed treatment control group. So these were women, again, a sample of gynecologic cancer survivors. Almost 90% of them had both ovaries removed, and all of them reported lack of desire at baseline. And there was no effect of simply waiting for treatment on any of our measures of sexual response or satisfaction, and significant improvements on every measure of sexual response and sex-related distress. We then said, well, if this is really to be useful and fill a gap for survivors, we need for it to be accessible. And so we took our intervention and modified it for an online asynchronous delivery, so there was no interaction with a healthcare provider on the other end. There was no interaction with people who were logging on to the onto the intervention at the same time. And we brought this to samples of colorectal and gynecologic cancer survivors. And among the colorectal survivors, we had a mix of men and women separately participating. And so they did the 12-week intervention on their own. In men, we only saw an improvement in sexual desire, but in women, we again saw these significant improvements on all domains of sexual response and reductions in their self-reported depressive symptoms. So we then did a number of uncontrolled studies. One of them was controlled, two of them were not, in women primarily with the symptom of low desire. Again, the most common reported sexual concern that women and men have. So this chronic low level of desire, lack of interest in sex, and associated distress. And whether it was in 3-session format, 4-session format done individually, or 8-session format done in group, we started to see this, again, consistent picture arise from pre-treatment to post-treatment, significant and clinically meaningful improvements in sexual desire, overall sexual function, which is a composite score of desire, arousal, orgasm, and satisfaction, and reductions in sexual distress. And that then led us to obtain funding for a large RCT, which we've just finished, where in addition to looking at the efficacy of 8 sessions of mindfulness versus a sex education control group, and I'll take a bit of a digression here, the paper that we have on the bottom there refers to the real difficulty in defining what is a control group in general in the psychological literature, and in particular in the domain of treatment of sexual concerns where expectancies are so high. So it's not enough to just have a delayed treatment or no treatment, or treatment as usual even, which is nothing. We need to be able to control for some of the non-specific factors. So essentially our control group is everything we do in the mindfulness group minus the mindfulness. You might say, well, what's left? There's actually some information about anatomy and physiology, information about sexual response and the sexual response model, and mostly educational information, a little bit about communication. So we just finished this RCT, and we're in the process of collecting the last of our 12-month post-treatment follow-up data in the next 2 months or so. The second question that I've been really interested in this particular study is, how does this work, right? So is it that mindfulness just improves mood? Is it that it regulates stress? Is it that it reduces distraction? What are the underlying mechanisms actually point to how mindfulness is working? And so this slide shows some of the different things that we've included in this study. So we've looked at concordance, which is the extent to which a woman's physical response to sexual stimuli agrees with her self-reported response. And there's a well-known characteristic of women's sexual arousal that often those two are discordant. A woman might be becoming physiologically aroused and her mind is turned off, is elsewhere, or the opposite. Mindfully engaged, present, aroused, and body is not responding. So we're looking at the extent to which mindfulness improves concordance. We're also measuring intraceptive awareness, which is a person's ability to really know what's happening inside their body. It's like those people who know their heart rate, know their blood pressure, know when they ovulate. Those are high intraceptively aware people. We have different measures of the hypothalamic pituitary adrenal axis response, looking at diurnal cortisol rhythms, as well as self-report measures of stress. We're looking at inflammatory markers, C-reactive protein. That's a great partnership we're doing with Joanne Weinberg. And then looking at a number of baseline moderators that would predict who's doing well with mindfulness versus the control group. We have a treatment manual, and these are some of the mindfulness exercises on the slide that we do. So within each 2-hour group, half of that group, a full 1 hour, is dedicated to us practicing mindfulness and then doing an inquiry afterwards. So stay tuned, because pretty much all of 2020 will be devoted to analyzing this massive data set of information. So we've also brought mindfulness to a different population of women who experience a condition called provoked vestibulodynia, or PVD for short, which is a chronic, distressing genital pain condition when the vulva or vagina are provoked. So tampon, sexual activity, gynecologic exams, sometimes women can experience shooting pain depending on the kind of clothing that she's wearing. The seam on jeans can elicit this distressing pain at the same time. It's really a complex condition that's puzzling for healthcare providers to manage. And the placebo-controlled trials of the most commonly used medications like lidocaine, gabapentin, find those medications to be no more useful than placebo. So it's really a puzzle for us in the healthcare setting, is how do we best manage it. There are data that suggest that multidisciplinary treatment that brings together gynecologic care, pelvic floor physiotherapy, and psychosocial skills training is probably the best approach. And so within that, we were funded by CHR to complete an RCT comparing 8 weeks of mindfulness to 8 weeks of cognitive behavioral therapy, again, as one tool among the multidisciplinary approach in managing women with genital pain. So this is a study we call COMFORT, and we've had a few papers published already from the COMFORT study. We've got a treatment manual for CBT that we've developed, a separate treatment manual for mindfulness that we've developed. All of the attributes of the participants are in the papers, but essentially what we found, to orient you to these slides here, from baseline, which are the blue bars, to immediately post-treatment, the red bars, and then green, which was 6 months later. and I don't have the 12-month data in this slide, although we do have those data, we see this significant reduction in women's self-report of pain. And in fact, the mindfulness group was more effective than the cognitive behavioral therapy group, which is interesting because we originally designed the study as a non-inferiority design, basically to say mindfulness is no worse than CBT. And we found for the primary outcome it to be more effective. We had other measures of pain, so physician elicited pain with this handy little device called a vulvogesiometer. We found reductions in sexual distress, again, that continued for 12 months. Pain catastrophizing, so this is the tendency to imagine the worst with the pain. This pain is never going to go away. I'll never be in a relationship. I'll never be able to have a pap smear for the rest of my life. Those sort of catastrophic beliefs that women with PVD experience, and found rather dramatic reductions in those. And really importantly, when we look at women's clinical significance or their global response to this, they were very satisfied with the treatment and reported overall improvements in the quality of their sex life as well. Okay, I'm going to skip through possible mechanisms and end with a couple of really important points, and that is, you might be wondering, does mindfulness just work for the people who have drank the Kool-Aid, right? So these are already people who are meditating, who have read the mindfulness books, who've gone to the retreats. What about the skeptics? And so this is something we've been consistently measuring in our research over the last 8 or 9 years or so. And we have yet to find any impact of baseline confidence in the treatment and believability of the treatment on any of our outcome variables. So how I interpret that clinically is mindfulness is as effective for those who don't believe it's going to work as those who really believe it's going to work when we're looking at these outcomes of sexual function and genital pain. There has been a lot of criticism, I think really appropriate criticism in the mindfulness literature, which has pointed to the fact that among mindfulness researchers, we're using definitions of mindfulness very differently, right? So some might be describing just paying attention as mindfulness. Well, that's not really mindfulness, right? It's paying attention on purpose, moment by moment, non-judgmentally. Or are we including controls? Or are we including experienced facilitators in delivering the mindfulness intervention? So I think all of these concerns are really appropriate, and I've personally seen mindfulness researchers do better as a result in terms of really describing their methods and being aware of the potential caveats, because if not, we risk the potential conclusion, which is we've discovered a panacea. And although, of course, that's what we all want, the literature is far from concluding that we've found a panacea. So I'll end by putting out a call for knowledge translation. There's a well-known 17-year gap between science and its translation into policy, practice, some other use of data. And here's where the use of evidence-based KT tools and strategies and frameworks can really ensure that our scientific findings get used in the most appropriate way. And so we've had a few different social media campaigns as one form of KT, funded by the Michael Smith Foundation, and we just got a second one to do a separate social media campaign based on our desire and mindfulness study. But last year we ran a 6-month social media campaign in partnership with Erica M., who runs an online company called Yummy Mummy Club, has about 10 million readers and subscribers each month that read the information, and it was a way for us to share the findings from our study of mindfulness for women with provoked genital pain. We have a number of different outcomes, but one of the outcomes we were really interested in was our reach. And we found that our video that we produced reached 45 different countries, and most people watched 90% of the 2-minute video, so great metrics there. Other forms of KT involve, we've got 9 treatment manuals that we make available to clinicians and researchers, and over the years we've tracked who's using our treatment manuals, how are they using them clinically or in research, and then we ask them to report back on their findings so that we can start to build a bit of a database on who else is using them. And of course, that becomes really important for the replicability concern that we have, which is, you know, our lab has shown all these great findings, but can these be reproduced elsewhere? Lisa mentioned the book, which summarizes some of the main findings in the treatment of low desire. So I'm going to end with the Dalai Lama's statement, if you want others to be happy, practice compassion. If you want to be happy, practice compassion. And so although the research has really focused on mindfulness as a tool for those in need, I can say that among our team and our experienced facilitators that it's been just as personally gratifying to be involved in this work and have the ability to run these groups and practice alongside. And whenever we start a group, we make a commitment to our participants that we do all the same exercises that they do. We ask them to meditate for 30 minutes a day. We meditate for 30 minutes a day. So we're alongside with them. So with that, I'll end and see if we've got 2 minutes for questions. Thank you very much for your attention. Oh, sure. And how do I know if any of the other sites have questions? Okay. So if anyone who's logging in, not in the room, if you have a question, just unmute and feel free to ask your question. Yes. Do you know any predictions about what biological mechanisms might correlate best for your responders and non-responders? I assume there's something that doesn't. Yeah. It's a great question, and it's not something we have the ability to measure in my lab, although it certainly is being looked at for, especially in the depression literature and in the chronic pain literature. Is there some kind of a signature, whether it's a neural signature or some other indicator where we can actually predict and therefore use precision health to say you actually would respond well to this or not? What we do have is we have a paper which is in the final stages of getting accepted to look at mediators among women with provoked vestibulodynia. And there we actually found some pretty significant differences, both baseline predictors as well as mediators of efficacy in the mindfulness versus